This video explores real events from an educational and investigative perspective. It's shared with respect for everyone affected, focusing on understanding what happened and why. True crime isn't just about what happened, it's about understanding why. If you value that approach, consider subscribing. Your support through likes helps this content reach others who think the same way. Now then, from the outside, the pediatric clinics and hospital wards around San Antonio, Texas looked exactly the way parents hoped they would. Bright walls, quiet hallways, nurses moving quickly between rooms while worried mothers and fathers waited beside small hospital beds. It was a place built on trust. Parents trusted the nurses carrying medications into exam rooms. Doctors trusted the people assisting them during emergencies. And families trusted that every person wearing a medical badge had dedicated their life to protecting children. But over time, something unusual began happening. Children who had arrived for ordinary care suddenly stopped breathing. Some collapsed without warning. Others entered medical distress moments after routine treatment. And strangely, one nurse often seemed to be nearby when those emergencies unfolded. At first, nobody thought much of it. In fact, many people believed her presence during crises proved she was exceptionally dedicated, calm under pressure, quick to react, always willing to help during emergencies. But there's more to this story than meets the eye. Because years later, investigators would begin asking a terrifying question. What if the person appearing to save children had actually been creating the emergencies herself? And that's what makes this case so significant. Genene Jones was born on July 13, 1950. By the late 1970s, she had entered the medical field and was working as a pediatric nurse in Texas. To many coworkers, she appeared deeply committed to her patients. Pediatric nursing requires emotional endurance. Nurses working with children often face frightened parents, long overnight shifts, and emotionally difficult situations. The environment depends heavily on teamwork and trust. Doctors rely on nurses for constant monitoring, medication management, and emergency response. In many ways, nurses become the emotional center of pediatric care. And this is important to understand psychologically. Hospitals operate on systems of assumed trust. Medical workers are trained to cooperate quickly because hesitation during emergencies can cost lives. That environment can sometimes make it difficult to recognize warning signs when behavior falls outside normal expectations. What's interesting from a psychological standpoint is that people who appear calm during moments of panic are often viewed as highly competent. In high-stress environments, composure creates credibility. According to co-workers from that period, Jones often appeared exactly that way, calm, confident, helpful during emergencies, and at first, those qualities earned admiration. She eventually worked at Bexar County Hospital in San Antonio, one of the largest teaching hospitals in the region at the time. The facility handled large numbers of pediatric cases, including critically ill children. Medical emergencies happened regularly there. Staff were used to pressure. They were used to chaos. But over time, some co-workers began noticing something difficult to explain. Children seemed to experience sudden medical crises, unusually often around Jones. At first, the incidents appeared unrelated. One child would suddenly stop breathing. Another would enter unexplained distress. Doctors would rush into rooms while nurses attempted emergency intervention. In many cases, Jones was already there helping manage the situation. Nobody realized the pattern yet. And that's an important detail. Human beings are naturally resistant to seeing patterns that threaten trusted systems, especially inside hospitals. The idea that a caregiver might intentionally create harm feels emotionally incompatible with the purpose of medicine itself. So instead of suspicion, many staff members interpreted the situation differently. They believed Jones was simply the nurse most willing to respond during emergencies. That interpretation would matter later, because the same behavior initially viewed as dedication would eventually become one of the most disturbing aspects of the investigation. But during those early years, concerns remained vague, difficult to articulate, more instinct than evidence. Some doctors reportedly felt uneasy about the unusually high number of pediatric emergencies during her shifts. Others noticed that crises seemed to follow her between departments, yet none of those observations alone proved anything. And hospitals are busy places. People second-guess themselves. They assume coincidence before intent. To understand why, we need to look at another psychological factor common in institutional environments: normalization. When unusual events happen repeatedly over time, people sometimes begin unconsciously accepting them as part of the environment, especially if no clear explanation exists. Researchers studying institutional failures have observed this pattern in hospitals, corporations, law enforcement agencies, and even aviation systems. Small warning signs become background noise. And that's what makes this case so significant, because many of the signs later viewed as obvious had once seemed easy to dismiss. Jones eventually left Bexar County Hospital and later worked at a pediatric clinic in Kerrville, Texas, a quieter community northwest of San Antonio. The setting was different there. Instead of a massive urban hospital, the clinic treated families from a smaller town environment. Parents brought children in for routine care, vaccinations, fevers, checkups, everyday pediatric concerns. It should have been a calmer workplace. But the emergencies continued. Children who appeared stable suddenly entered respiratory distress. Others experienced unexplained reactions shortly after treatment. Staff members again found themselves scrambling during sudden crises. And strangely, Jones often appeared nearby when those emergencies happened. But one detail kept resurfacing. She didn't panic during these situations. While others rushed frantically between rooms, Jones reportedly maintained an unusual level of calm. Some co-workers interpreted that as professionalism. Others later wondered whether the calmness reflected familiarity. The distinction would become critically important years later. What's interesting from a criminological standpoint is that some healthcare offenders develop what experts call a hero syndrome behavioral pattern. In these cases, a person creates or escalates emergencies in order to receive attention, praise, or emotional validation during the rescue attempt. The goal isn't always death itself. Sometimes the individual wants recognition, importance, control. Investigators would later explore whether that dynamic existed here. But at the time, nobody fully understood what they might be seeing. And this is where things take a turn. Doctors at the Kerrville Clinic began noticing that several unexplained emergencies shared uncomfortable similarities. The timing felt wrong. The medical explanations didn't fully fit. And in some situations, children deteriorated unusually fast after otherwise routine treatment. One physician reportedly became concerned enough to pay closer attention to medication handling inside the clinic. That concern would eventually prove crucial, because by the early 1980s, suspicion inside the clinic was beginning to grow. Quietly at first, then all at once. And then another child stopped breathing after what should have been an ordinary appointment. This time, doctors noticed something they couldn't ignore. The concern inside the Kerrville Pediatric Clinic didn't arrive all at once. It built slowly. One unexplained emergency became two, then three, then more. Doctors began noticing that children who had arrived for relatively ordinary appointments were suddenly experiencing life-threatening medical distress. And the timelines often didn't make sense. Some children deteriorated unusually fast. Others showed symptoms that didn't fully match their original conditions. Staff members found themselves rushing patients into emergency intervention with increasing frequency. At first, physicians searched for medical explanations. Maybe the clinic was seeing unusually fragile patients. Maybe there were complications nobody understood yet. Maybe the emergencies were simply tragic coincidence. But coincidence becomes harder to accept when patterns repeat. And this is where things take a turn. One physician reportedly became especially troubled by the frequency of respiratory emergencies occurring around Genene Jones. According to later reporting, the doctor began paying closer attention to medication handling and treatment procedures inside the clinic. That decision would become incredibly important, because eventually concerns moved beyond instinct. They began entering the realm of physical evidence. One of the most troubling discoveries reportedly involved a bottle of succinylcholine, a powerful medication capable of causing paralysis under controlled medical conditions. A physician allegedly noticed evidence suggesting the bottle had been punctured. The detail immediately raised alarm, not because it proved intent by itself, but because it suggested the possibility that medications inside the clinic were being altered or improperly handled. And suddenly, the unexplained emergencies no longer felt random. What's interesting from an investigative psychology standpoint is that institutional suspicion often develops in stages. At first, people reject the possibility of intentional harm because it conflicts with their understanding of the environment. Hospitals are designed to heal people. Pediatric clinics are associated with care and protection. So investigators and even medical staff frequently look for every possible accidental explanation before considering deliberate misconduct. But eventually, evidence forces perspective to shift, and in Kerrville, that shift was beginning. Meanwhile, the emergencies continued. Parents brought children into the clinic expecting routine treatment, vaccinations, illness evaluations, follow-up appointments. Most families had no reason to feel concerned. The clinic appeared professional, organized, familiar. But behind the scenes, tension among some staff members was growing. And then came the case that would permanently change the investigation. Chelsea McClellan was an infant brought to the clinic for what should have been a normal pediatric visit. Nothing about the appointment initially appeared unusual. According to reports from the investigation, Jones administered injections to Chelsea during the visit. Shortly afterward, the child stopped breathing and entered critical distress. The reaction was immediate and terrifying. Medical staff rushed to intervene while emergency efforts began around the infant. Doctors attempted to stabilize her condition as panic spread through the clinic. But despite those efforts, Chelsea later died. And this time, physicians believed something was deeply wrong. The timing surrounding the collapse immediately drew scrutiny. Medical professionals reportedly questioned whether the emergency aligned with a normal reaction to routine pediatric treatment. The answer appeared increasingly unlikely, and that's what makes this case so significant. Because Chelsea McClellan's collapse became one of the moments investigators could no longer comfortably explain away. What's important to understand is that many healthcare-related crimes remain hidden specifically because medical emergencies happen naturally inside hospitals and clinics every day. Patients deteriorate unexpectedly, children react unpredictably to illnesses, complications occur. That reality creates investigative difficulty, but patterns still matter. Repeated emergencies surrounding the same individual eventually begin attracting attention, especially when timelines, symptoms, and outcomes fail to align medically. And in Kerrville, staff members were beginning to notice exactly that. Some physicians reportedly started documenting unusual incidents more carefully. Others became increasingly uncomfortable with the recurrence of unexplained collapses. Questions that once felt unthinkable were now entering ordinary conversation behind closed doors. Could someone inside the clinic be causing these emergencies? The idea felt impossible, but the evidence was becoming harder to ignore, and this is where institutional psychology becomes extremely important. Researchers studying healthcare misconduct often point to a phenomenon called authority shielding. In trusted professions, people unconsciously protect colleagues from suspicion because acknowledging potential harm threatens the emotional stability of the entire institution. In simple terms, believing a trusted caregiver could intentionally hurt children is psychologically difficult for most people to process, so warning signs sometimes remain buried longer than they otherwise would. This case later became one of the most studied examples of that phenomenon. Investigators eventually focused heavily on the timing of the medical emergencies. They reviewed patient histories, medication access, shift schedules, witness observations, and as they examined the clinic more closely, the same troubling pattern kept appearing. Jones was frequently nearby when children unexpectedly entered crisis. Now, here's the detail that changes everything. What initially looked like dedication suddenly began appearing very different under investigative review. The nurse who always arrived during emergencies was now being examined as someone potentially connected to the emergencies themselves. That reversal changed the entire direction of the case. And from a psychological standpoint, it's one of the most disturbing aspects of healthcare-related investigations, the very behaviors that earn trust in medical environments. Confidence, composure, constant involvement during crises can sometimes conceal deeply manipulative patterns. By the early 1980s, investigators were no longer simply reviewing unexplained incidents. They were building a criminal case. The investigation expanded beyond individual emergencies and began examining broader patterns connected to Jones's employment history. Authorities revisited earlier cases from hospitals where she had previously worked. Medical experts reviewed records looking for similarities in symptoms, timing, and medication exposure. And what they found raised even more concern, because the Kerrville incidents no longer appeared isolated. The possibility emerged that unexplained pediatric emergencies had followed Jones across multiple facilities over several years. For families connected to those cases, the realization was devastating. Parents who had once blamed themselves for mysterious medical tragedies were suddenly hearing investigators suggest another explanation entirely, one rooted not in random illness, but in deliberate interference by someone entrusted with children's care. And that's what made the investigation emotionally overwhelming for so many people involved, because hospitals represent safety. When harm appears connected to that environment, it doesn't just damage individual families, it damages public trust itself. Investigators were no longer asking whether something unusual was happening. They were asking whether someone inside the healthcare system had been causing it all along. By the time investigators began fully reviewing the case against Genene Jones, the atmosphere surrounding the investigation had changed completely. What had once looked like isolated medical tragedies was now being examined as a larger behavioral pattern. And the deeper authorities looked, the more disturbing the similarities became. Medical experts reviewed patient histories from multiple facilities where Jones had worked. Investigators compared timelines, emergency reports, medication access records, and witness statements. Physicians who had once questioned their instincts privately were now speaking openly with investigators, and one detail appeared repeatedly. Jones often seemed present when unexplained emergencies occurred. That observation became critically important because the pattern wasn't limited to one child, or one clinic, or one unusual incident. Investigators believed they were looking at repeated medical crises connected to the same caregiver across several years. Now, here's the detail that changes everything. The very behavior that once made Jones appear trustworthy was now being interpreted differently. Her calmness during emergencies. Co-workers had originally viewed that composure as evidence of professionalism, but investigators later questioned whether the calmness reflected something else entirely, familiarity with situations that she may have helped create herself. And that's what makes this case so psychologically significant, because many healthcare-related offenders don't fit public expectations of dangerous behavior. They often appear organized, helpful, cooperative. In some cases, they become deeply embedded inside systems built on trust and compassion. That contradiction makes detection incredibly difficult, especially in hospitals. Especially around children, investigators eventually focused on evidence suggesting that dangerous medications had been administered improperly to pediatric patients. Authorities believe Jones had introduced substances capable of creating sudden medical collapse, including drugs that could trigger respiratory distress or cardiac emergencies. According to prosecutors, the goal may not always have been death itself. Instead, investigators believe Jones may have wanted to create emergencies where she could participate in rescue efforts and receive praise afterward. From a psychological standpoint, experts later connected this behavior to what criminologists sometimes describe as attention-seeking or hero syndrome dynamics. In these situations, individuals manufacture crises in order to position themselves as important during the response. The emotional reward comes from the chaos itself, the attention, the admiration, the perceived control. But in medical environments, those manufactured emergencies can quickly become fatal, and that's exactly what prosecutors argued had happened here. The case surrounding Chelsea McClellan became central during trial proceedings. Prosecutors presented evidence that Chelsea's sudden collapse after routine treatment was not medically consistent with a normal pediatric reaction. Investigators also introduced concerns involving medication tampering inside the clinic, and suddenly, earlier warning signs no longer seemed disconnected. Remember the physician who reportedly noticed puncture evidence involving medication handling? That detail now carried enormous weight. What once looked like a strange irregularity became part of a much larger investigative picture. And the same was true for the repeated emergency patterns surrounding Jones's shifts. The callbacks were everywhere. The nurse who always seemed nearby during crises. The unusual calmness. The repeated collapses following otherwise routine care. Individually, each detail had once seemed explainable. Together, they formed a disturbing pattern investigators could no longer ignore. On February 15, 1984, Jones was convicted in connection with Chelsea McClellan's death and additional injuries involving pediatric patients. She received a sentence of 99 years. Later, during a separate trial connected to another hospital, Jones received an additional 60-year sentence involving other harmed children. For many families, the verdicts brought some sense of closure, but not complete peace. Because one of the most painful aspects of the case involved uncertainty surrounding the total number of children potentially affected. Over the years, investigators and journalists questioned whether the confirmed cases represented only part of a much larger pattern. Some estimates suggested significantly more children may have experienced unexplained medical emergencies connected to Jones's employment history. And that's what made the case continue haunting investigators decades later. Not just what could be proven, but what might never be fully known. What's interesting from a historical standpoint is that this case helped reshape how hospitals monitor unusual medical patterns today. Modern healthcare systems increasingly track statistical anomalies involving patient emergencies, medication access, and staff-related incident clusters. In many ways, cases like this changed institutional oversight permanently. Hospitals became more aware that dangerous behavior inside medical systems can sometimes hide behind professionalism and routine authority. And this leads to one of the most important educational lessons in the entire story. Institutional trust is necessary, but blind trust can become dangerous. Experts studying healthcare misconduct often emphasize the importance of transparency, peer accountability, and early reporting systems. One person's instincts, one physician noticing an unusual pattern, can sometimes prevent future harm, and that's why whistleblowers matter. Because in environments built on hierarchy and pressure, speaking up against a trusted coworker can feel almost impossible. But sometimes, those uncomfortable observations save lives. Decades after the original convictions, the case returned to public attention once again. Not because Jones had been cleared, but because of a controversial legal issue involving sentencing laws in Texas. Due to prison regulations and overcrowding policies from that era, Jones eventually became eligible for release much earlier than many families expected. The possibility created outrage among relatives connected to the case, many of whom argued she still posed a danger. And then another major development occurred. In 2017, authorities indicted Jones again in connection with the death of an 11-month-old child from an earlier case. The new charge prevented her release and returned national attention to the investigation decades after the original convictions. For many people, the announcement reopened emotional wounds that had never fully healed. And this is where the story becomes larger than one individual case, because the Genene Jones investigation forced difficult conversations about healthcare oversight, institutional accountability, and psychological warning signs inside trusted professions. It also changed how many investigators approach so-called angel of death cases involving medical workers connected to unusual emergency patterns. Today, researchers studying healthcare-related offenses often examine this case as an early example of how dangerous behavior can remain hidden when institutions fail to connect warning signs quickly enough. And that's what makes this story endure decades later, not just because of the crimes themselves, but because of the lessons. The danger of unquestioned authority, the psychological complexity of attention-driven behavior, the importance of pattern recognition, and the reality that trust, while necessary, should never replace accountability. Because sometimes the most important warning signs are the ones people are afraid to believe.